femtocorneal allogenic intrastromal ring segments, known as CAIRS, for moderate to severe keratoconus. This is Shady Awwad from the American University of Beirut, Lebanon. So CAIRS are part of therapeutic refractive surgery for keratoconus. And they were introduced by Susan Jacob back in 2015 and made more popular in 2017. They are meant to be an alternative for PMMA corneal ring segments. Now, corneal ring segments have been a great boon for us refractive surgeon in treating keratoconus. However, they have complications just like any other procedures. And a not so uncommon complication of a otherwise perfect surgery is stromal melt. Stromal melt can have different scenarios of presentation, from a small epithelial defect to thinning of the cornea to frantic melt and a stromal defect, as you can see here. Now, sometimes again, when we look and see a mild epithelial defect over a corneal ring segments, if we run an OCT on it, we will discover often that this runs all the way deep to the PMMA segment, and that sometimes again we see thinning of the stroma, no deep cleft, but just thinning over a corneal ring segments, typically here over hexagonal ring segments, which were the old SKs, which had a lot of mechanical stress on the stroma. The late J.C. Awwad published his data using hexagonal intacs and mostly using keratomes, and it was 7% over 10 years of acute stromal necrosis. Our data published in JRS using intacs SK and using only femtosecond procedures and all deep, about 375 micron to 400 micron depth. We still had something close to that, 5% within 10 years. Another complication is actually anterior chamber intrusion, typically seen in triangular PMMA segments, and often when keratoconus patients that rub their eyes. And then again, sometimes we see neovascularization frequently when the segments are a little bit closer to the limbus. Traditionally, the procedure is performed using the double-bladed Jacobs trephine. We debride the epithelium and the endothelium. We trephine, we get an annulus, a stromal annulus, we cut it by half. And then we mark the corneal vertex. We use the three-prong marker to extend the mark on the corneal vertex. I dock here using the Zimmer Z8. And I make sure that the tunnels don't have any bridges. I leave the segments to dehydrate here on a corneal shield, trephined to a 5 to 6 millimeter optical zone. You can see that the segments are pretty rigid here. They look like intacs or PMMA segments. Another way is also to use the Awwad CAIRS mold, that actually you could place the segments there to dehydrate with an optical zone of 5 to 6 millimeter. Again, now you can see the segments, how rigid they are. It's just like using a PMMA corneal ring segments, and you can introduce them, you can push them. I usually like to pre-program an incision from the opposite end to pull the segment from using Asinsky, and then I iron any twist. I want to discuss CAIRS first as a primary intervention. And I would discuss our data that actually just got accepted in the Journal of Refractive Surgery. We looked at a minimum of 3 months and a mean follow-up of around 7 months. The reason why the minimum 3 months, because most patients end up having cross-linking plus or minus topographic PRK. So nobody gets it before 3 months, but after 3 months, as soon as the patient gets this treatment, they exit the study. That's why we have a minimum of 3 months and a mean of 7 months before getting the cross-linking procedure or cross-linking plus. And then we use, in this study, we use the 750 micron Jacobs trephine and the 500 micron trephine. We use the LEV Z8 to perform a tunnel of 900 micron width and of 250 to 300 micron depth. As you can see here, there is a huge number of eyes that gain 2 lines or more, about 81% of them. There is a major improvement both in UDVA and CDVA, as you can see, a major shift towards the 2040 to 2030 group. An improvement in keratometry, typically a Kmax improvement of about 5 diopters. Also a major improvement of K-mean, also about 4 diopters. The vertical coma improved by about 0.9 diopters, and that's pretty good. We looked at segmental tomography, and we defined the inner epithelium inner to the segment. We programmed an algorithm to average those epithelial thickness sector. And then we also looked at the cone. We averaged it over the cone as defined by the Gaussian curvature on the MS-39. And then when we looked at epithelial thickness and stromal elevation, what we found out is first that we have 1 week out, we have a decrease in the maximum stromal elevation. And again, the stromal elevation is actually the elevation over a best fit sphere without the epithelium. So the MS-39 takes away the epithelium and then plots the best fit sphere, and that's the elevation above the best fit sphere. And that's what we call stromal elevation. So we have an improvement 1 week, and then we have stability, which means we have structural improvement in the cornea by 1 week and then stability after. However, when we look at the epithelium, we see a constant thickening of the epithelium inner to the corneal ring segments up to 1 month, and then a stability after 1 month. So let's exemplify this clinically. This is preoperatively, and again, after we introduce the CAIRS at this position, then we have a major improvement, as you can see in topography. If you look at stromal elevation, 3 days out, we have a major decrease in stromal elevation. However, if you look at the epithelium didn't budge, didn't have the time yet to reorganize 3 days out. But if you look at 1 month out, we see a whopping thickening of the epithelium inner to the corneal ring segments, to the allogenic ring segment, the CAIRS. And again, if you look at OCT, you could see thickening just proximal to the allogenic segment. Now, if you look again at the epithelium over the cone, so we said there is stromal flattening, there's a decrease in elevation at 1 week and then stability. There is an increase in the epithelial thickness inner to the allogenic ring up to 1 month and stability. But what we see here is actually a decrease in epithelial thickness over the cone at 1 week, which is very paradoxical, knowing that we have a decrease in stromal elevation. So what we know from the rules of the epithelium, as we know from Dan Reinstein, the work of Dan Reinstein and others, that actually if you have a flattening, we should have thickening of epithelium. If you have steepening, we should have a thinning. Here, it's paradoxical. Actually, we have thinning over the cone for the first week while we have decrease in stromal elevation. But then slowly we have thickening again all the way up to 1 month and a little bit further out. Now, what's happening here? So let's take a look at the topography to understand what's happening. So again, this is baseline at A, B, C, D. This is improvement 1 week, 1 month, 3 month post CAIRS. This is tangential curvature. Okay, as you can see here, there is definitely improvement up to 1 month, stability at 3 months. If we look at the epithelial thickness, there's definitely a thinning that happens at 1 week. Then we have thickening again from 36 to 44, and then stability at 3 months. If you look at the elevation, stromal elevation, again, there is an improvement, a whopping improvement at 1 week, but then a little bit of improvement, maybe just a little bit at 1 month, but not much, and then stability all over. If you look again and compare, definitely we have thinning of the epithelium at the same time where we have flattening over the cone. Now, why is that? That's because most likely what's happening is that the epithelium over the cone is going to the rescue, trying to fill the gutter inner to the ring. And that's why it's fleeing out the cone to get thicker. These are the neighboring cells. But with time, what's happening is that we have time for the other epithelial around the CAIRS, probably from the limbus, from the adjacent area, to come in and repopulate. And then you'll have a shift of balance again from those thicker epithelium now back to the cone. And that's why sometimes we see that there is an improvement at 1 week, and then we have a little worsening at 1 month, and maybe some gradual improvement again up to 3 months. So this explains sometimes what we also used to get with corneal ring segments, with the PMMA segments as well. And these are the three topographies on, side by side. You see that B, we have a major improvement in topography, but then you have C, a regression a little bit, and a little bit of an improvement by D by 3 months. As far as complications, we had tunnel roof tear by 1.6% because the tunnel here is done at 250 micron. We have transient epithelial erosion over the CAIRS that got better at 1 month and then improved, and no rejection till now. So now I want to take a look at what we can do after CAIRS. We have combination of CAIRS and customized PRK and cross-linking. This is preoperatively, that's 4 days CAIRS, and that 1 month CAIRS, major improvement again. And then what we did here is topography guided trans-PRK with cross-linking. And as you can see, major regularization. Look at before and look at the final central value, major regularization of the cornea. Now, CAIRS as secondary intervention. In this case, we have a Kira ring that has intruded. We have published that in the Joint Refractive Surgery case report. We took that Kira ring out, but what we did is actually we implanted a CAIRS exactly at the same position, but much shallower. And that's the advantage of CAIRS, because they're allogenic. They can be implanted at 250 microns. In this case, there's no way we could have implanted another PMMA segment because of the perforation that stayed after the removal of the Kira ring. But here, because the CAIRS can be implanted at 250 micron without melt, because they're allogenic, we get even better effect because they're much shallower. So what we got, this is preoperatively and that's postoperatively. Even with the Kira ring, because it was deep, the cornea was very protruding, the cone was very protruding. And now, as you can see, we're putting a shallower ring segments, we got a much better effect and much more regularization. We have published again in JRS our experience in exchanging PMMA segments in eyes that have anterior stromal necrosis by corneal allogenic ring segments. So we have shown a much better improvement than actually just removing the cornea, the PMMA segment. And then I would like to share this case where you could supplement the effect of pre-existing corneal ring segments. Again, we have published this in the Journal of Refractive Surgery case report. This is an index SK that was put at 7 millimeter optical zone by mistake by my resident. So what it did, it actually did help. It centralized the cone, but the cone was still very steep and really smack in the center of the eye. So what we did here, instead of removing the cone and dealing with a decentered steep cone, we dealt with a centered steep cone by implanting CAIRS at 4.5 to 5 millimeter optical zone that is at 250 micron depth. So again, that's something that you don't dare to do with PMMA segments because they introduce glare and halos. But with a allogenic segment of a similar index of refraction as the cornea, the glare and halos are minimal, and the patient improved dramatically. I'm not going to discuss the postoperative results because of we're short of time, but that's something that you could see in our publication. Again, if you look at the OCT, that's very nice to see a CAIRS and a PMMA segment coexist. We could understand also how these segments interact. They're of similar size. Maybe the PMMA segments is a little bit thicker, but if you could see after compression, the PMMA segment is 255 micron deep, 400 microns got decompressed to 255, while with the CAIRS, they got it's sitting at 168 to 187 micron depth. That's again after compression from 250, and this gives you an idea why these segments act better, because they're actually shallower. So in my mind, CAIRS definitely was a game changer, but it needed more customization, more accurate trephination, and that's why I thought I could do that with a femto laser. So I teamed up with Zimmer. We developed on their platform, on the Zimmer Z8, a software that could cut using an artificial chamber. So this is how it works. We're docking the Z8 on the artificial chamber by OCT. We know exactly our depth. We can decide on the location of the ring, and here we could trefine. You could cut multiple rings in the same cornea, as you can see here, and then you could score them easily and peel them easily, as you can see. And then finally, they look really nice as opposed to the PMMA segment. They integrate very well into the cornea, and an OCT, the silhouette of the case is really sharp. Again, there are endless possibilities like asymmetrical femto CAIRS. We have also got our paper accepted in JRS using femto asymmetrical CAIRS. This is a duck-shaped cornea by using an asymmetrical planning 500, 500, and 750. What we end up is actually a cornea ring segments implanted into the cornea with different thickness profile after compression, as you can see. So this is preoperatively, and that's postoperatively a major improvement. And the other eye, again, something similar with an asymmetrical segment, major improvement. So finally, customize all laser CAIRS definitely add more customization. We don't need an inventory because we can do it right at our center. At the same time, they can be done in eye banks as well, so not necessarily in your center. That's something great for other surgeons. And then they can be combined with customized PRK, with cross-linking, with PACE, with ICL, with so many other technology to serve best keratoconus eyes. Thank you.